So our final speaker is going to be Maysa Walters, and Maysa did her practicum with the Mayo Clinic in Rochester, Minnesota, with Dr. Ellen Good, who's in the Department of Quantitative Health Sciences at Mayo Clinic. And the name of Maysa's presentation is Molecular and Clinical Features of High-Grade Serous Ovarian Cancers in BRCA1 and BRCA2 mutation carriers. So I'll let you take it away, Maysa.
Hi, everyone. Thank you, Lee, for the introduction. My name is Maysa Walters, and my project is Molecular and Clinical Features of High-Grade Serous Ovarian Cancer in BRCA1 and BRCA2 mutation carriers. As Lee had mentioned, my site was at Mayo Clinic's Division of Epidemiology, where I worked under Dr. Ellen Good as a graduate intern over the summer of 2023. So an overview of my presentation, I will go over what my deliverables for my project were, a summary of my project, an explanation of the abstract and related poster, as well as the results and key findings, and the conclusion from our research. As mentioned, I worked in Rochester, Minnesota at Mayo Clinic as a grad intern for the summer of 2023. I worked in the Quantitative Health Sciences Division of Epidemiology. Our work focused on genetic and molecular epidemiology of cancer, primarily studying ovarian cancer. However, some studies required us to change our thinking and focus more on additional types of cancers, including lung. This presentation will encompass my two deliverables, including an abstract poster presentation written for the American Society of Human Genetics conference, as well as a brief component for my data analysis in the results and findings section. The abstract was titled Molecular and Clinical Features of High-Grade Serous Ovarian Cancer in BRCA1 and BRCA2 mutation carriers. To give context, high-grade serous ovarian cancer is one of the 5 main types of ovarian cancer. However, high-grade serous carcinoma is the most malignant form of ovarian cancer. As for BRCA1 and BRCA2, they are 2 genetic mutations that are most commonly known for their attribution to breast cancer, but also represent one of the most significant genetic risk factors for high-grade serous carcinoma. Therefore, our research aimed to better understand the clinical and molecular correlates for affected mutation carriers. We recruited participants from Mayo Clinic's Project Generation with a total sample of 209. Project Generation is a joint research partnership between Mayo Clinic's Biobank and Regeneron Pharmaceuticals that yields whole exome sequencing on the entire Mayo Clinic's Biobank. Approximately 56,000 participants, as well as an additional 44,000 Mayo participants from Mayo studies on patients with cancer, cardiovascular, neurologic, and other conditions were looked into for our study. This collaboration is a result of many years of planning and discussion, and the goal of the research partnership called Project Generation is to learn more about genetic causes of disease and role of genetics in treatment and outcomes for research. Our research established exclusion criteria using medical record abstraction. We were provided with age of diagnosis, disease stage, extent of residual disease, and neoadjuvant treatment, whether or not an individual received chemotherapy. Using a ClinVar database, pathogenic mutation was defined as likely pathogenic or pathogenic. High-grade serous ovarian cancer cases for our methods was pathogenic germline mutations in BRCA1 and BRCA2. For BRCA1, our sample size was 117, and for BRCA2, it was 92. We identified these participants through comprehensive gene-based sequencing. RNA extracted from fresh frozen tissue was integrated with gene expression for estimation of tumor molecular subtype. Molecular subtype can reflect important biology, developmental origins, and most importantly, have clinical utility. Additionally, tumor cores of actual tissues on tissue microarrays were scored by CD8 tumor-infiltrating lymphocytes. CD8 TILs play a key role in killing tumor cells. Therefore, we aim to study the influence of CD8 TIL scores on survival time. The statistical analysis used Cox regression and a Kaplan-Meier survival analysis. Below is the poster created during my time at Mayo Clinic. The figures display the association of gene mutation carriers by molecular subtype, as well as a 5 and 10-year survival from the survival analysis with BRCA2 and CD8 TIL scores. The APE competencies for my abstract and poster deliverables included Competency 1, applying epidemiological methods to the breadth of settings and situations in public health practice. Competency 3, analyze quantitative and qualitative data using biostatistics, informatics, computer-based programming, and software as appropriate. And Competency 4, interpret results of data analysis for public health research, policy, or practice. Shown only in the results of my final deliverable was a data analysis performed in R software. The data analysis also suited competencies 3 and 4. November 2nd through the 5th was the ASHG conference located in Washington, D.C. Unfortunately, I was unable to attend, but Dr. Good was able to present the poster on my behalf. As you can see from the last slide to this, a few changes were made to the poster. The poster presented included statistics on characteristics of study participants and distribution of tumor features, which were found through the data analysis done in RStudio. Rather than a bar graph, a pie chart was included to compare mutation carriers by molecular subtype, but the data remained the same through the two figures. Key findings and results from our research. The overall mean at diagnosis was 58.5 years. 92.5% were recorded at advanced stage and 23% received neoadjuvant treatment. Surgeries left no macroscopic disease for 59.2% of cases, and the 5-year overall survival of high-grade serous ovarian cancer was 47.1% in our research. As expected, older age, advanced stage, and macroscopic disease was associated with a shorter survival time. BRCA1 mutation carriers were more likely than BRCA2 mutation carriers to be fully surgically resected with no macroscopic residual disease. However, among cases with chemo-naive tumors, BRCA1 mutation carriers were less likely than BRCA2 mutation carriers to have mesenchymal molecular subtype tumors. This finding is inconsistent with the premise that mesenchymal tumors may be more challenging to resect. Additionally, BRCA1 mutation carriers were less likely than BRCA2 mutation carriers to have an immunoreactive molecular subtype. Although frequencies of CD8 TILs were similarly distributed among both mutation carrying groups, there was no difference in survival time between BRCA1 and BRCA2 mutation carriers after adjustment for age, stage, residual disease, molecular subtype, and CD8 TILs. And you can see that last statistic from the two graphs located below for the CD8 TIL scores. In conclusion, laying the foundation for larger scale analyses results suggest a potentially complex interplay between tumor molecular subtype, surgical resectability, and immune features in high-grade serous ovarian cancer differs by germline BRCA1 and BRCA2 mutation status. Again, favorable survival time with higher levels of CD8 TILs and BRCA2 mutation carriers was noted, and CD8 TILs were similarly distributed between BRCA1 and BRCA2 mutation carriers. That concludes my presentation, but I do want to give a special thank you to Dr. Good for her support and guidance on this project. Without your time and effort, this project would not have been possible. And I'd also like to give a shout out to Lee. Thank you you were with me through it the whole summer and all fall. So thank you for your time with everything.
Thanks, Maysa. Nice job.